Thank you, thank you. But you all know what the challenge is going to be for me right now. Yes. I have to follow the protocol here in Nigeria to make sure I recognize everybody, correct? So what I'm going to do is take the easy way out. I will recognize the president, and of course the past presidents, and I will beg the indulgence of my participants, but I know a lot of you, and a lot of you know me, so I'm already recognizing you guys, but that is really the challenge, but it's an honor to be here today. And most people ask me, you fly all the way from US and you come here. Why do you do that? It's easy. I'm passionate about what I do. This is my country. We have to give back. We go there, we get the knowledge, and we bring it back. That is what it is. I really want to acknowledge Professor Sufo. That presentation he gave, is phenomenal. He is telling the story of what the best practice is. But I will say, I've been coming to Nigeria for years, but every time I come, there's an improvement. We are heading in the right direction. It is not as bad as we think. We still have some work to do, obviously, but we are heading in the right direction. But before I start my little short presentation, I bring greetings from my president in US, not Trump. Dr. Kule Tometi from NAPSA. He sends his greetings. But I'm here to speak on nutrition support in pharmacy practice. So I'm here to talk about my NGO, WASPN, and what I'm doing, and I'm also here to make a case for collaboration with pharmacy PSN, and I will explain why. I think you guys already know what WASPN means. West African Society of Parenteral and Enteral Nutrition. He says my topic is nutrition support in pharmacy practice. Well, let me clarify something. I'm going to be talking about nutrition support of the sick patients. Patients who are in the hospital, hospitalized patients. I'm also going to be talking about nutrition support really as it pertains to when the patient is being discharged to the community. That is what I'm going to be talking about. So, that's WASPN. There you all can see on the slides what WASPN is. I guess people will ask me, why did you choose WASPN? You're in Nigeria. Why not NASPN? I chose WASPN because Nigeria is where I'm going to start. But my plan is to go all over West Africa with this nutrition support. Actually, 3 weeks ago, I just formed a chapter in Ghana. So I've already started in that movement. All right. Now, WASPN leadership, if you all look at it, it's not just pharmacists. Not only am I sending the message of collaboration with PSN, but I'm also sending the message that we need to start doing what? Using multidisciplinary team approach. So it's not just pharmacy and medical doctors and nurses and dietitians, that this is a multidisciplinary team approach. That the patient-centered care that we're talking about, it takes multiple disciplines to do. And what WASPN is doing, hopefully, will address that gap we have here in Nigeria. And you all know what the gap is. Medical doctors, the relationship we have with medical doctors and all that. I think this will help address that. This will show the value of pharmacists in a patient-centered care model. This will show that pharmacists are valuable. You all heard everything they said. My background, I'm a pharmacist. a clinical pharmacist, but I'm board certified in nutrition support. I run a metabolic support service in US. I taught medical doctors. I taught nurses. I had a team, medical doctors, pharmacists, nurses. That's what, so a pharmacist can be a champion. That's the point I'm making. So if we can do it in US, why can't we do it here? So there's room. So that's where you all can see. So it says right there, membership are pharmacists, physicians, dietitians, nurses, and allied health. Right now, WASPEN has close to 200 plus members here in Nigeria. They are doctors, pretty much what you've seen there. Next slide, please. Now, why do we want to collaborate with Pharmaceutical Society of Nigeria, PSN? We're preaching that multidisciplinary bridge, I already mentioned. We always have to be thinking multidisciplinary. You cannot do anything alone. Physicians cannot do it alone. Pharmacists cannot do it alone. Nurses cannot. We have to do it together. Pharmacy is always at the center. We need to keep thinking of that. The WASPEN, and I have a pharmacy subgroup in WASPEN. We also have to be thinking capacity. How do we train people to have this knowledge, capacity building? And then, of course, you have to look at your advocacy and policy. Next slide. Now, what I did, knowing that PSN is made of community pharmacists, hospital pharmacists, academia, industry, nutrition support touches every one of them, that technical group. Nutrition screening and assessment. For the community pharmacists, you can incorporate nutrition screening into your practice. When your patients come to get your medication, you need to ask them, what is going on with their weight? Have they lost weight? What kind of medication they're taking? What impact does it have on their food? So nutrition screening and assessment. You can also think about nutrition planning. You can employ a dietitian that can be a consultant if you really need to do more of that. And then, of course, nutrition delivery and the monitoring and adjustment. Next slide. Again, this is stressing that nutrition support is multidisciplinary and that the pharmacist is right at the middle in terms of patient-centered care. There you can see the physician. The physician, again, has to diagnose the patient like he does with everything. The dietitian does the nutritional assessment if the patient is in the hospital. The patient is in the middle. The nurse, once the patient is diagnosed as being malnourished, and if they're in the hospital and their gastrointestinal tract is not working, and they need parenteral nutrition, who is the discipline that really works with the physician to make sure that formulation is appropriate, that if it needs to be compounded? Who do you think it is? If the patient is malnourished and the gastrointestinal tract is not working, meaning he can't, even if he eats, he will not absorb it, and he needs IV nutrition, what discipline becomes the key to make sure that you have the right formulation, is compounded appropriately? Who is the discipline? The pharmacist. Who is the discipline that ensures that the nutrition assessment is done? And then once the formulation is done and it is hung, who monitors the patient? Is it just a nurse? Everybody monitors the patient. So does that mean that because the dietitian is the one that has the background to do the assessment, does it mean the pharmacist will not have any knowledge of how to do it? No, they will. but it's the dietitian. So the point I'm making is, it's a multidisciplinary team approach. Next slide. Nutrition support in the hospital has to be integrated into pharmacy practice. Nutrition support is a specialty for pharmacists. Clinical specialists, you can specialize in nutrition support. You're not taking anybody's job. You collaborate with the dietitian, with the nurse, with the physician. So it can be integrated into medication and nutrient interactions. Pharmacists are the ones that have the knowledge. Patient safety, you have to make sure that the formulation is done correctly, that you're looking at the patient's electrolytes and all that. That's what patient safety is. Compounding, and when I'm talking about compounding, I'm talking about sterile compounding. If I tell you guys how many times I've had calls in US about a neonate that have not made it because they do not have the compounded solutions, parenteral solutions. There's a big need. Children are dying. Sterile compounding in pharmacy, in the institutions. So it's very, very important. Chronic disease management. You have elderly patients, maybe who have diabetes, they cannot eat, but nothing is wrong with their GI tract, but they just can't eat. What do you do with them, with those kind of patients? They are in the hospital, they're sick, their gastrointestinal tract is working, but they cannot eat enough to maintain their nutrition. What do you do with such patients? Do you feed them parenterally? Should you? Feed them parenterally, their gastrointestinal tract is working? No. That's where you do what they call the force feeding. You do enteral alimentation. You put a feeding tube to their nose, to the stomach, or sometimes they can put a long-term feeding tube, so they call that enteral nutrition. So the point I'm making is, pharmacists should have knowledge of this two, parenteral and enteral nutrition. Now, if the patient was on enteral nutrition in the hospital and they want to be discharged home, should you continue to leave them in the hospital because of enteral nutrition, or can you continue it at home? You can continue it at home. Again, pharmacy knowledge. So if you have a community pharmacy, that could be services you can provide. Are you all following me? Am I making sense? You see? So the multidisciplinary clinical collaboration I already talked about. Clinical respect. Next slide, please. So hospital pharmacy, I already talked about that. All right, so enteral nutrition, I already gave you guys a brief knowledge. Enteral nutrition is for patients who are malnourished but have functioning gastrointestinal tract. You have to force feed them. That's where you put the feeding tube. So that's what that is. That states the pharmacist's responsibilities in parenteral nutrition and enteral nutrition, as stressed sterile compounding. There are two types of parenteral solutions: the sterile compounding or the premixed. Pharmacists play a key role right here. You are involved in the stability, you are involved in the macronutrient calculation, micronutrient. Right now I'm working on a project with one of the biggest pharmaceutical companies here, because I'm not really sure that we have sterile rooms in most hospitals. And most of the manufacturing companies have the sterile, aseptic technique, because if you want to do the compounding, it must be done in a sterile environment. That is a key. All right. So, but that's something the pharmacist you ought to think about. So that is the pharmacist's responsibilities when it comes to parental intro. Next slide. Community pharmacy. What should the community pharmacists think of? These are the things the community pharmacists can do. There's a speaker after me. She's going to be talking about the nutraceutical, what the community pharmacists can do in terms of nutraceutical. But these are things that community pharmacists, you can be involved in chronic disease nutrition counseling. You can counsel them in the diabetic patient. You can monitor their weight and be involved in the obesity management. Give recommendations for medications. You know, dietary supplement counseling. The food-drug interaction education. The pharmacist has knowledge of that. I also mentioned about the malnutrition screening in the elderly. It is very, very important the pharmacists can do that. Then health promotion and community education. And the pharmacist can have an arrangement with a dietitian. You can consult them when it comes to food planning, so they can be part of your team. This is something of business-wise that the pharmacist can do. So for the community pharmacists, these are key nutrition services. Next slide. Industry. So the pharmacist in industry, is nutrition support important? Yes, it is. If they have knowledge about nutrition support, they will be able to know what kind of products they need to bring in, you know, to formulate. So and you can also see like the product development and manufacturing, the quality assurance and regulatory affairs, and even research. So there's need for nutrition knowledge for that population. Next slide. Academia. This is really something that I think we need to really look at also seriously. Nutrition needs to be integrated into the curriculum. Because a lot of times, if students are not introduced about nutrition in the school, then obviously they don't have any clue when they come out. So integration of nutrition is very, very important. All right. And we also, like in US, we also have them in rotation. They do the experiential learning and postgraduate training. You all heard Professor Suko talked about postgraduate training. So that's what he was talking about, the residency. So I did 2 years residency in nutrition support. So there's an opportunity for residency for that. And then of course, research and knowledge generation. Next slide. There's also need for nutrition support in regulatory and public health pharmacy. So NAFDAC also needs to be involved when it comes to nutrition. They are the ones that do the regulatory of all the products, so knowledge is needed there. Dietary supplements regulation, the labeling, you know, then also the public health pharmacy. You know, these are all areas that nutrition support touches. You know, so again, next slide. Next slide. So what are some of the ideas that WASPEN has for strategic value to collaborate with PSN? One is we want to expand clinical capacity. How do we do that? Training. Like I give yearly conferences. Like this year, the conference will be in Asaba. It's usually like a 3 days conference. And it's for everyone. It's for pharmacists, dietitians, physicians. So they come to that conference and then we do they hear clinical topics. So that is one area. Expand clinical capacity. WASPEN can work closely with PSN and do that, you know. And then we can also lead national nutrition efforts, you know, and then elevate the visibility of malnutrition in hospitals. WASPEN is focusing in hospitals, trying to increase the awareness of malnutrition in the hospital. So already we have like 4 institutions that we did conferences in, and we started multidisciplinary nutrition support teams in those hospitals. So those are some of the things, and we also can reinforce the advocacy efforts, you know, and then do like regional and global network access. So there's a lot that WASPEN could do with PSN to really, for the collaboration. So what are some of the expected outcomes? What PSN and Nigeria can gain from this? We can have a structured national pathway for clinical nutrition. Again, I'm referring to the hospital. And this will help promote the value of pharmacists. A pharmacist can be the champion in the hospital. If you're a champion, you can work with any of the doctors, and that can be done. You see, you can strengthen multidisciplinary collaboration. So the physicians can start seeing how valuable pharmacists are, you know. It can also enhance reputation of PSN as a clinical leader. Well, PSN already have a strong reputation, you know, but this will help strengthen it in terms of their members. And then we can have sustainable education, research, and patient outcomes. You know, and not to talk about the global visibility for Nigerian pharmacists. So again, these are some of the expected outcomes that if we do this and do it, you know, do it the way we've already talked about, we can see all these kind of outcomes. Next slide. Right here we have like a three-phase implementation roadmap. And of course, this is something we're going to have to discuss with the leadership. We have the phase one, what is going to be, you know, the foundation and establishing the structure, and then phase two, and then the phase three. But this is something that the two groups have to sit together, but it is doing. Next slide. Well, so the purpose of this presentation is just to give you all a sense of what WASPEN has in mind. To give you all a sense of malnutrition among the sick patients in the hospital here in Nigeria. To let you all know that this is actually one study really called it a skeleton in the closet. And you all know what that means. That malnutrition is a skeleton in the closet of most hospitals. Malnutrition, people do not think about malnutrition until you really see the implications of malnutrition. I don't know how many of you have relatives or patients who came into the hospital, they came for a surgical procedure, their wounds did not heal. That's one of the complications of malnutrition. Or they were in the ICU, they were on the ventilator. They couldn't get them off the ventilator. Complications of malnutrition. I told you guys about many times premature babies, they do not get malnourished, but they do not have the right solutions. So malnutrition is real. Now, does pharmacists, do we play a role in making sure combating this? Yes, we do. Can we do it alone? No, you cannot. It has to be a multidisciplinary team approach. Can this kind of approach help address these issues we have with collaboration? I think it will. So I think that is the purpose why WASPEN felt we needed to collaborate with PSN and see. I remember years ago when you were the registrar and we were talking about family, the registrar, we never knew what was going to happen. But look at it today, which our past registrar here, you made it all happen. You know, so that's what it will happen. So really having specialty areas for pharmacists, really improving on that collaboration with physicians, I think it's going to happen. So that's the purpose of me trying to do this today. So next slide, I think is the last slide. That's the last slide. Let's build it together. That's what the last slide said. Yeah, so, and here we can look at different ways. So thank you all for listening, and I'll be glad to answer any questions when you have.